Um, Dr. Aditi, we are live, please.
Yes.
We can start.
So I'll just share my screen. Yeah, so is the screen visible now?
Yes, it is visible.
And I'm audible as well?
Yes.
Oh, thank you. So, good morning, everyone. I welcome you all to this fine Sunday morning session, episode 15 of AIS GuruSangam 2025. Now, it is truly a Sangam. It is a dynamic learning, it creates a dynamic learning environment that seeks to educate individuals, empower them to excel in their pursuits, and to elevate their potentials. Therefore, it is educate, elevate, and excel. And I would, like to thank President AIOS, Dr. Samar Kumar Basat, who heads the Disha Eye Hospital, Kolkata, for providing us with this platform and bringing together ophthalmologists from different parts of the country to share their experiences and their knowledge with all of us. I would like to thank the program directors, Dr. Santosh Punawar sir, Dr. Dr. Santosh Nawar sir and Dr. Manoj Mathur sir, who have created this inclusive platform, bringing together ophthalmologists from different parts of the country to share their experiences and knowledge with all of us, and therefore providing it, making this truly a Sangam of Gurus. So I'll move on to the expert panel. We have, we have 7 experts on today's panel who have various decades of experience of being in the profession, in this fraternity, teaching and training students and fellows, undergraduates, postgraduates, and so on. And all of them clearly known and have had left a mark, have a mark on their respective fields. Firstly, we have Dr. Abdul Waris. He is a VR consultant at Aligarh Muslim University. He has vast training and teaching experiences, both VR and anterior segment surgeries. And he's also got several publications to his name. I welcome you, sir. Dr.
Sorry to interrupt. Can you just wait for a minute?
Surely.
You can continue, ma'am.
Yeah. Then we welcome Dr. Abdul Waris, sir. We
Thank
have
you,
with us Dr. Asim Kumar Ghosh, sir. He is the director and professor of RIO, Kolkata. Several, he's been a part of several medical colleges all over West Bengal. He was even awarded the Best Teacher Award in Ophthalmology in the Kolkata Conference of 2020. And, having trained so many undergrads and postgrads over the years, sir, we'd like to, get to know about your experience as well. We have Dr. Girish Rao, sir, who is a a distinguished ophthalmologist. He's with Shankar Netralaya, Chennai. He has several years of experience in VR, and his areas of expertise is ocular trauma, diabetic retinopathy, scleral fixated IOLs. We welcome you both, Dr. Asim and Dr. Girish Rao, sir.
Thank you.
We have with us Dr. Veer Singh, who comes from a family of legendary ophthalmologists. He's the VR person at SB Dr. Sohan Singh Eye Hospital in Amritsar. And he's a VR surgeon there. And, your experience and your knowledge would be truly, helpful for us in this session too. We welcome you, Dr. Veer Singh. We have with us Dr. Jatinder Singh. Sir is a senior VR surgeon and UVR consultant at Eye Foundation, Coimbatore. And he is also involved in training several postgraduates and fellows over the years. And he's always a part of most of the panels and panel discussions. So that experience will truly help us today as well. We have with us Dr. Karubi Lehri, who has several decades of experience in training, teaching. She's a VR person. She's also a pediatric opthal consultant, and she has authored several chapters in various books on diabetes and other things. And we welcome you, Dr. Karubi, ma'am. We also have with us Dr. Sarita Berry. She's the Director, Professor of Ophthalmology at Lady Hardinge Medical College. And so to be, head of a premier institute like that, and to have seen so many undergrads, postgrads, and trained so many hundreds of students over the years, ma'am, that's truly a fabulous experience, ma'am. We welcome you too. Moving on, our first speaker for today is Dr. Rajvinder Kaur, ma'am. She's professor and head, the Adesh Institute of Medical Sciences and Research Center, Bathinda. Her MBBS has been from Amritsar. She did her postgrad from Medical College, Patiala. Over several publications in index national and international journals, and several awards and accolades to her name. Good morning, Dr. Rajvinder Kaur, ma'am. And she'll be talking to us today regarding lasers in diabetic retinopathy.
Thank you, Dr. Aditi, for introduction. And I want to thank All India Ophthalmological Society, Santosh Onawar sir, Manoj Mathur sir, and Sama Basak sir for giving me this opportunity. So I will be sharing my screen. Good morning, respected panelists. So is it visible?
Yes, it is.
I am audible also?
Yes, very clear.
Okay. So I will be speaking on laser in diabetic retinopathy. So the learning objectives will be the laser basics, types, delivery modes to highlight the basic protocols of laser photocoagulation, to provide the practical tips for lasering and newer lasers, and trials related to PRP. No financial disclosures. At this platform of GuruSangam, in the journey of my life, a mentor's guidance is the most enduring gift. So I want to thank and grateful to my mentors. So that is diabetes is on the rise. 422 million adults have diabetes. That is one person in every 11 person is having diabetes. And 16.9% of the people have diabetes or have diabetic retinopathy. And 3.6% of have diabetic retinopathy, which can cause the loss of vision, means the vision threatening diabetic retinopathy. So what is laser? Laser is the light amplification by stimulated emission of radiation. This can be asked in for the postgraduates. So I have prepared it like for the postgraduate students. So what is the difference between the that is the ordinary light and the laser? The light moves in waves. That is, ordinary lights like household bulb or the flashlight comprises multiple wavelengths which are incoherent. Means and they travel at different wavelengths and different directions. But in laser beam, the light waves are coherent. They travel in the same direction in the same wavelength. So what are the properties of the laser? It is a high energy, monochromatic, coherence, polarized and collimated, which travels in one direction with high energy. So coming to the history of laser. So in the history, in 1916, Albert Einstein laid the foundation of the laser. And later on, the Gordon Gould did work on the laser research and coined the word laser in 1920. And in 1945, Gerhard observed that during the solar eclipse in northern January, many patients developed the solar retinopathy. So this was his research behind we are getting that is coagulation. He is known as the father of that is coagulation. So this is the first sunlight photocoagulator which was developed, and how it was used we can see in the picture. And the third picture, when he was coagulating the retina using a xenon coagulator. So he is the first working laser. He developed the first working laser in ophthalmology. That is, it was by the Theodore Maiman in 1960. He utilized a pulsed ruby laser coupled with monoocular direct ophthalmic system. So the common wavelength of laser light with application in retina. So most commonly we use the argon green and the diode green, which falls in the wavelength of 532, and the PDT, which falls in 689, and the anti-YAG laser, that is more than 750. So now what is the principle of the PRP in diabetic retinopathy? The most commonly asked question. So the laser, when it interacts with the tissue, it can have three effects: the thermal effect, the photochemical effect, and the ionizing effect. But here in photocoagulation, that is in diabetic retinopathy, we will be studying the photocoagulation. So in photocoagulation, when laser light hits the retinal pigment epithelial cell, it is absorbed by the melanin pigment, and heat is generated, that is 50 to 100 degrees centigrade. And it is an irreversible process which denatures the proteins. And there is loss of biologic activity of the retinal pigment epithelium cells and the photoreceptor cells. So there is a coagulation of tissue. So which are the pigments in the retina? So it is absorbed by the melanin pigment, which is in the retinal pigment epithelium and the choroid, and the macular xanthophyll, which are located in the inner and the outer plexiform retinal cells. So what is happening in diabetic retinopathy? Normally, we all know that there is a ischemia in the periphery in diabetic retinopathy. So there is hypoxic retina. So by photocoagulation, what we are doing, we are converting the hypoxic retina into the anoxic retina. So their demand of oxygen is decreased, and there is downregulation of angiogenic factors and VEGF level, because the hypoxic retina produces the VEGF levels. So that the increased oxygen perfusion to the remaining viable retina is improved. So we will be targeting we should target the hypoxic retina, which will be visible on angiography, set laser only to the ischemic and the CNP areas and avoiding the areas of perfusion retina. So how we'll decide the PRP is to be done or not? So there are many factors such as the clinical, in the history. In the history, we'll be seeing the duration of diabetic retinopathy. And secondly, the systemic risk factors, they also plays a role in deciding the treatment. And third, there is the compliance to the treatment, the follow-up. If the patients are compliant, we can do some other procedure. But if they are not compliant, we usually go for the PRP. And then history of rapid progression and poor control of systemic parameters, they are also the decisive factor. So on clinical examination, first of all, the vision and the IOP on every visit of diabetic patient, we know that it should be done. And on the first, that is slit lamp examination, always look for the neovascularization of the iris and the angle. And always document even if it is not present. We should learn to document it. And the gonioscopy should be done in all diabetic patients to rule out NVA. And the good metabolic control is an integral part of the diabetic management. And the second, that is coming to the ocular imaging. Imaging and management are complementary to each other. So the fundus photograph documentation is very important, as it is important for patients counseling and so as to improve the compliance of the patient. And the role of that is fundus fluorescein angiography is very important in deciding the PRP, because it is the baseline evaluation for the retinal vascular diseases. And secondly, we come to know the even the subtle NVI, that is neovascularization of the disc or the neovascularization elsewhere if it is present. And especially the ischemia, how much the ischemia is there, especially in the periphery, we can see with the help of only with the help of angiography. So it can help us in guiding the laser. Especially we can also see the macula if it is well perfused or the ischemic maculopathy is also present. And it will be helpful in deciding the treatment of the diabetic macular edema. And also it should be done if the patient's that is laser PDR is having a vitreous hemorrhage or there is to know if there is persistent NVE or NVT. So when there is a hazy media and we are not able to sure about the status of the diabetic retinopathy, the classification, and then in the presence of asteroid hallosis and the cataract, we can plan the angiography. And that is wide field imaging in retina is very important these days, because it is proven from the studies that 11.7% of the PDRIs, the retinal vascularization was only detected only with the help of wide field imaging. And it was not covered with the 7-field imaging, which we do with the normal fundus camera. So it detected more of the CNP areas and the neovascularization, which is in the periphery. So it is coming important to have a wide field imaging. And OCT also plays a role in deciding the whether we are regarding the diabetic retinopathy management, that if it is there, diabetic macular edema is there along with the proliferative diabetic retinopathy. So we will treat the cystoid macular edema first, diabetic macular edema first. So the presence of the OCT biomarkers we can see, and assessing the vitromacular interface, it is very important in deciding the management. And the extent of the posterior highlight separation. So if it is there, we will be treating the diabetic macular edema first, and then we will be doing the PRP. So the Octa is also coming these days very. So it can detect the mild perfusion defects, especially in those patients where we are not able to do the fundus fluorescein angiography, like the kidney patients who have chronic kidney disease. In those patients, we won't be able to do the fundus fluorescein angiography. In those patients, we can always do the Octa if we have accessible to the Octa. So we can see the NVE, subtle NVE, and we can see the capillary non-perfusion areas. So it is very good tool in the armamentarium to be, if it is available. So it is we can have the better understanding of the foveal avascular zone, and we can see the regular pruning of the vessels. So it is very helpful in detecting the PDR, and it can improve the clinical examination with the potential to replace fundus fluorescein angiography as a diagnostic tool. So the basic concept of ocular treatment is we have to decrease the load of VEGF. And we can do it by two mechanisms, that is converting the hypoxic retina to anoxic retina by doing the photocoagulation, that is PRP. And second is the anti-VEGF. So that is PRP we usually do for the PDR patients, and laser for the, there are two types of laser, PRP and the laser for the diabetic macular edema. So what are the indications? That is, indications are high risk PDR, that is proliferative diabetic retinopathy. And when we have very severe NPDR in the one eye and PDR in the other eye, the ocular ischemic syndrome, preoperatively before doing the vitrectomy for tractional retinal detachment, and neovascularization secondary to diabetic retinopathy. But in severe cases, when we should decide to do the PRP, when the patient is one-eyed, patient is a young patient, and poor compliance to follow up. And in pregnancy, when the disease is progressing, and in nephropathy, and before doing the cataract extraction, and poor control to the systemic parameters. And on angiography, we had wide area of non-perfusion areas. So what are the delivery systems available? So we normally do with the slit lamp delivery and the endo laser. That is, we can do the fill-in PRP if it is already lasered while doing the vitrectomy for the vitreous hemorrhage or tractional retinal detachment. Or if it is not done, you can do the PRP in one sitting only. So these are the three delivery modes, and indirectly ophthalmoscopic delivery can also be done. So it is always important that before doing the procedure, we should know our machine and different parameters. So the first is the spot size. It is usually it is available there on the slit lamp machine. And second is the duration. Duration. So we can see here that is the duration. So we can do our settings. That is the duration between the two spots. We can see the two spots. So it is the duration between the two spots. You can, according to your speed, you can do that. And this is the power. How much power is to be used? This is the for the beam intensity. And this is the number of spots given. And from here we can start. When we are ready, we can start this by clicking it here. So what are the lenses available to us? So there are two types of the lenses, direct lenses and indirect lenses. Normally we use these types of the lenses. So normally for the PRP, I use PRP 165. The image is inverted and there is a wider view. And when sometimes it is not available, we can always use the Goldman contact lens, which has a concave lens and diameter of 12 mm diameter. Image is upright. And you can, that there are 4 lenses. It is this lens is important for the postgraduates to know that there is central lens. We can see up to the 30 degree of view of the posterior pole, and that is oblong shape lens where we can see up to the 67 degree mirror. It is we can see up to the ora serrata and pars plana. And then it is a rectangular lens where we can see up to the equator. And fourth lens is used for the gonioscopy. So normally we use the PRP 165 lens, and we can see the image magnification is 0.1 times, 0.51 times, and the laser spot magnification is 1.96, and the field view is 165 to 180 degree. And the contact lens used for the focal laser is the mainstay standard, and the laser spot magnification is 1.05, and the field of view is 90 to 121 degree. So when we are doing the PRP, we can see that is keep the slit at the axial. And first of all, when we got our patients, it is always to confirm the patients, always confirm the patient's name, the eye to be lasered, and the laser advised. And always explain the procedure to the patient, take the informed consent, and people should be well dilated, examine the fundus, correlate the findings that the patients you are seeing and the which are documented in the records. So always correlate the patient. And topical anesthesia, wait for 2 minutes and then start the procedure. So always, whenever there is some attendant is there, always use protective glasses for them. Always check the parameters. And then starts the laser from the periphery. So give a spot and then see if the sufficient grade is coming or not. And if you are doing the anterior laser, it is always advised to lower the power and the duration. And if there is media opacity, you can increase the power or increase the duration or decrease the spot size. So always first give us some spot in the periphery, then see that the grade you want is coming or not. Whatever you are giving, it should be visible to you. So it is always very important to know the orientation. Always note the macula first. So it is very important. First of all, you should know where is the macula. So sometimes in diabetic patient have more of the CSME hemorrhages, but always orient yourself to the macula. And then shorten the laser pulse duration, especially at 3 and 9 o'clock hours, because the patient has the long posterior ciliary nerves. So patient may feel more of the pain. So always lower the duration. And preferably, the laser can be done if a patient is from nearby, you can plan the laser in 3 sitting. And if the patient is coming from a far distance, you can do 1 sitting or the 2 sitting. So the area of the distribution. So always mark the macula first by, we can see here, that is by doing the 2 rows of laser here. Okay. Then just begin temporally. Then we have to that is complete the inferior retina first. Because if there is, sometimes you have the PVD induced vitreous hemorrhage. So blood will settle inferiorly. So to avoid that, then you won't be able to do the laser inferiorly. So it is always advised to do the laser inferiorly first. And then you can, and you have to be 1 disc diameter, that is away from the disc. And that is, when we are doing inferiorly, we can just do up to the arcade of the arcade of, that is arcade. It's not moving.
All good, ma'am?
It's not moving now. It
Just click on the screen. You should be able to. Just
Yeah?
click on the screen once. Yeah,
Okay.
now you can move.
It's not moving.
Or you can stop and reshare, please.
Okay. Now it's moving. So in the PRP2, you can, that is, start the laser on the nasal side, 1 disc diameter nasal to the optic disc, and extend up to the as interior as possible. You have to laser. So the spacing between the, that is laser marks, 1 burn width apart should be the spacing between the 2 marks. And what we are aiming at, that is mild to moderate burn, mild to moderate burn. And you can give up to the 800 laser laser marks in 1 sitting. So we have to avoid the disc, the macula. Then it is the fibrovascular membranes. If they are there, we have to laser 2 to 3 disc diameter away from the that is fibrovascular membrane. Then it is a major blood vessels, hemorrhages, and if any neurovascular complex, because then we can have a vitreous hemorrhage after that. And temporally, we have to be, that is at least 2 disc diameter away from the macula. So that is a 2 disc diameter away from the macula we should laser. And interiorly means as much as possible we have to laser. And that is nasally, when we are doing it, we have to be 1 disc diameter away from the disc. And up to the arcade we should laser. So that is the complete PRP. So this is the, that is, you should document your findings, document the laser, number of spots you have lasered, the power used, the spot size, the duration, if you have any complication while doing laser, and the area treated. So you should always document the laser settings, etc. So the classification of that is the chorioretinal scars. We should normally want to see the threshold scar, that is the grade 3 burn. And when we are doing the macular laser, we want to mild burns, that is just visible to us. So we can see here in the picture the fresh laser marks, which will be visible to you as a white. And there should be 1 spot, that is 1 laser spot difference between the 2 laser spots. And when we see the old laser marks, they're usually pigmented with the hypo and hyperfluorescence in the periphery. So these are the laser that is settings. In the PRP, normally that is 200, 200, 200 can be the settings. That is spot size 200, duration 200, and power 200. We can do the laser in the case of PRP. And in the grid laser, we can keep the parameters 100, 100, 100. That is the spot size 100, duration 100, and power. And that is normally in the grid laser we do, that is 70 to 100 laser marks given. So in the focal, we can keep the spot size 50 and duration 100 and par 100. And that is, you can give up to the 20 to 50 laser spots. So the post laser, we should give the antibiotic steroid combinations. If there is any pain, we can give the homide and anti-glucagon medication on necessary. And indication, how will we decide that it is regressing, it is affecting? So after 2 weeks, just see the patient's new vessels disappear. In the long term, patient that is disc may become pale, absorption of the hemorrhage and venous changes and the fibrosis. So after 2 months, if you are suspecting, and you can plan the angiography again if patient is not that is having kidney disease, and just do the fundus fluorescein angiography and see if the new vessels are there or not. If still there is new vascularization, then you can do the targeted retinal photocoagulations. In cases that is failure of new vascularization to regress, increasing or that is new areas of the retina or the iris neovascularization, if there is new vitreous hemorrhage, so you can always do the fill-in PRP. So in between the laser marks, you can go give the laser marks, and you can go more anteriorly. And at the posterior pole, sparing the macula, 1 disc diameter from the center of the macula, you can add on laser. So benefits are more than the complications. We can have complications sometimes. We can have that is persistent nyctalopia, accommodative defect, reduced contrast sensitivity, photophobia. We can have constriction of the visual field, decrease in color vision and night vision. And if there is diabetic macular edema, always treat the macular edema first, followed by PRP. And sometime while doing laser, we sometime encountered the vitreous hemorrhage. So I have also told that always start inferiorly first. And there can be very rarely we can have the choroidal effusion, and there can be the precipitation of tractional retinal detachment. The focal laser, coming to the focal laser now. So that is, what are the theories behind the focal laser? So the few theories are the closure of the microaneurysm. Laser energy removes the unhealthy RP cells, which are then replaced by the more viable RP cells. Photocoagulation stimulates the existing RP cells to absorb more fluid. So the possible alternative route for edema to resolve through choroid. So laser treatment may stimulate vascular endothelial proliferation and improve the integrity of the inner blood retinal barrier. So in this era of the anti-VEGF, it is rarely done these days. And usually when it is done in the center non-involving DME. So whenever there is focal leak, we can always do the focal laser photocoagulation. When there is diffuse leak, we can always plan the grid laser photocoagulation. And it is mostly done on the slit lamp. So we can see here that is a modified ETDRS laser, that it means we are just whitening only the microaneurysm. That is 500 micron from the center of the fovea. We should laser the aneurysms. And that is ETDRS grid laser. That is laser is done in C-shaped manner in the that is in the temporal to the macula. The papillomacular bundle, we have to avoid that. So there was a DRCR net also given the MMG grid. That is mild burns throughout the macula with or without edema. No direct treatment of the microaneurysms, but mainly the modified ETDRS is followed these days. So the complications related to the focal laser, we can directly hit the macula. So we should be very careful while giving the focal laser. So there can be this CNVM formation when we if we go deep to the Brooks membrane, CNVM formation can occur. So the central vision and the color vision can impaired. And sometimes when we are giving the spots close, so the lateral creep with the enlargement of that spot can be occur. So we can see here in the that is fluorescein angiography, laser spots, central hypo surrounded by the hyperfluorescence. And on angiography, we can see in the form of the RPE defects. So recent advances, the Pascal semi-automated laser delivering system, it allows for the pattern of 4 to 56 burns to be applied in less than 1 second. The advantage is that is the duration is very less, 20 milliseconds. And it is a air-cooled anti-YAG laser with the help of slit lamp or indirect ophthalmoscopy. So that is, it is relatively painless, less time consuming, well tolerated, and more number of spots in single setting and very equidistant from each other. So less number of settings. So third is the navigational laser. It is a 532 pattern type eye tracking laser, integrates live color fundus imaging, red free and infrared fundus fluorescent angiography with coagulator system. So after image acquisition and making customized treatment plans by physicians, including marking areas, which will be coagulated, the treatment plan is superimposed onto the live digital retinal image during the treatment. So it is a fast, painless, better documentation, and wide field viewing system allows for the better accuracy. So then is the selective RPE therapy. It is the light is absorbed by the melanosomes in the RPE, and the application of the repetitive pulses of microsecond and sub-microsecond duration. So duration is decreased, resulting in selective damage to the RPE due to the formation of the small cavitation bubbles around the melanosomes, thus sparing the photoreceptors and the inner retina. So there is a RPE proliferation and migration restores the continuity of the RPE cells. So they lack the visible changes in retina. So the diabetic retinopathy studies, so I will be dealing only with the studies which deal with the pan-retinal photocoagulation. First study is the DRS study done in 1971 to 1975, which that is demonstrated the cause of PRP in reducing the risk of progression to severe vision loss with the high risk characteristic. Then the ETDRS study 1970 to 1985, which included the mild to moderate and NPDR cases also. Then in 2002, that is DRCS study, which included the AIS protocols. So the diabetic retinopathy study, DRS study, concluded that photocoagulation reduced the risk of visual loss by 50% or more compared with no treatment. So whenever there are high risk are present, prompt treatment with PRP is indicated. And then it is the early, that is the ETDRS study. That is when there is a severe ENPDR and early PDR, consider the scatter treatment, especially type 2 diabetes mellitus. And high risk PDR, the scatter treatment without delay. And if there is mild to moderate NPDR with CSME, focal coagulation. And when there was this CSME, do the focal coagulation. And then is the protocol A, which results that MMG is less effective at reducing the retinal thickening than the ETDRS technique. So visual outcome with both approaches was considerably different. So it is telling that modified ETDRS photocoagulation should be continued as the standard approach for treating the DMA. So protocol I, it compared that is intravitreal ranibizumab with the prompt and deferred laser is more effective at 2 years compared with the prompt laser alone for the treatment of the DME involving the central macula. So in pseudophakic eyes, the intravitreal triamcinolone and the prompt laser seems more effective than the laser alone, but frequently increases the risk of IOP elevations. And the protocol S, which result that is after 2 years of the follow-up, that is visual acuity is comparable in both the groups. So ranibizumab was not inferior to PRP in PDR at 2 years. So there is a one study, one case is there, that in which when we have the asymmetrical type of diabetic retinopathy, we should always do the carotid Doppler, because in such case, that is a small hyperechoic plaque in carotid bulbs with the left expanding into the left ICA was observed. So the patient may have the ocular ischemia also. So it was diagnosed that ocular ischemia along with diabetic retinopathy. So you have to see your cases also. So when the patient have the vitreous hemorrhage in the one eye and the very severe NPDR in the other eye, so we can always plan that is laser in the right eye first, followed by the injection of Avastin and PRP later on in the second eye. So in the conclusion, PRP is a well-established and effective way to prevent the progression of proliferative diabetic retinopathy and benefits weighs favorably against the complications. There is no risk of endophthalmitis and the systemic anti-VEGF exposure. The boom of intravitreal injection does not make laser obsolete. Cost, compliance, and practicality are mandatory considerations when individualizing and selecting the treatment for your patient. Thank you so much. Thank you.
Thank you, Dr. Rajwinder, ma'am, for your wonderful talk. It covered everything right from the basics up to the studies. One question I have, or I want to come in from each of the panelists present here. Is lasers for diabetic macular edema fading away slowly with the advent of all the newer anti-VEGFs? What is your take on it? And another question is, have you tried Protocol S in your practice? And if so, how has your experience been so far? So I'd like to start with Dr. Abdul Waris, sir.
Yeah, thank you for giving me a chance to be a panelist, and I would like to congratulate Dr. Kaur for a, I think, excellent talk. She covered everything. Regarding your question, you know that nowadays people are thinking that lasers are going to be off, and anti-VEGFs are almost replacing lasers, even in PDR. For your question, you are talking about DME. For DME, my protocol is that for central involving DME, I always go for anti-VEGF. I don't go for laser. For non-central involving DME, sometimes I do focal lasers also. I will stop doing grid laser nowadays. So I'm more towards anti-VEGF nowadays, and I think in the near future, anti-VEGF will replace totally lasers for DME. It's my take. But you have to see the Indian condition. Our patients are very poor. Their compliance is very poor. So many a times I still do focal laser in poor patients. But theoretically, when I go abroad and like that, when I work outside India, the protocol is that anti-VEGF has totally replaced lasers in macular edema. DME, it is anti-VEGF. Thank you.
Thank you so much. Dr. Girish Rao, sir, what is your take on the relevance of lasers in diabetic macular edema?
Yeah,
In
so I agree with the other earlier panelists that for diabetic macular edema, obviously, we now have a very good option of anti-VEGFs, and we have a variety of anti-VEGFs which not only give us the macular edema resolution, but also the duration, which is longer, so that the number of injections are less. So, as a protocol for diabetic macular edema, yes, the first line of treatment is anti-VEGFs or steroid, depending on what the prevailing condition is. But if it's a succinate retinopathy, where you just have a central microaneurysm causing a parafoveal leak, then yes, focal laser would still be the first line of treatment. That is probably the only indication where you would do a laser first, otherwise anti-VEGFs. Over a period of time, yes, there is going to be a fatigue both from the patient and from the treating physician, and there might be a need for reconsidering whether there is what we might term as an escape treatment, so where you want to come out of this repeated anti-VEGF or a steroid injections, and that's when you might need a focal laser or a grid laser or modified grade, only to reduce the number of injections for these patients. But otherwise, in pure science words, DME, the treatment of choice now is anti-VEGFs or steroids, depending on the case. For panretinal, for PRP, I think, especially in Indian condition, laser is the gold standard, and we would continue to do the panretinal photocoagulation. We have in our institute not initiated any studies or any protocols for the protocol S. So we have never done that. Our indication for an anti-VEGF for PDR would be either as a preoperative for making the patient relatively fit for an intraoperative procedure, or in a postoperative situation where the patient has repeated bleeds and you feel that you have kind of exhausted all the potential laser spots and the cryo. Yeah, there is probably a role of anti-VEGF in such conditions.
Thank you, sir. Dr. Jatinder Singh, sir, what do you still use a lot of lasers for the DME in your practice, sir?
I agree with the previous speakers and panelists. I think focal laser for extramacular microaneurysms, even if the edema comes to the center, I would try to do focal laser. And in patients with diffuse DME, where the edema is much more as compared to the microaneurysms and the leaking short capillary segments, I would continue to give anti-VEGF therapies and add steroids as and when needed. Regarding the pan-retinal photocoagulation, we haven't I haven't ever done anything related to what Protocol S mentioned, that anti-VEGF is non-inferior to PRP. And I think it is very clear that if you lose a patient to anti-VEGF therapy, loss to follow-up, you are back to square one in cases where you have started with anti-VEGF. Whereas in a PRP, even if you have done little, it is something which you're going to add up from there and not going to back to square one. So the chances of loss of follow-up is very high in our part of the country and the part of the world. And I think laser PRP still will and always will remain as a mainstay of PRP for a very long time to come for PDR.
Thank you, sir. Dr. Karobi Lahiri, Dr. Lahiri, what is your take on it? How relevant it is in your practice, the lasers in DME, and of course, Protocol S. Have you had any experience with that?
Thank you, Aditi. I completely agree with the previous three speakers onto the protocols which have changed over a period of time, where earlier lasers were the only thing that we were used to. And after the advent of anti-VEGFs, we have switched our preference to anti-VEGFs for center involving DMEs. And I agree with Dr. Girish that sursinates or small microaneurysms which are causing major leaks, we would try to do a focal laser, because as a combination, it always works better. And if a person is lost to follow-up, as Jatinder says, that at least we have some amount of laser to hold on to whatever effects you have had with the laser. Now, the thing is that my preference definitely would be for an anti-VEGF and, if required, a supportive laser. Whereas for NVs outside, where we have a PDR, I would also prefer a laser along with an anti-VEGF if there is a combination of a DME with peripheral neovascularization or neovascularization elsewhere. Rajvinder, you covered the topic very well. In fact, you highlighted on small points which all the PGs, etc., have to know. So it was a very well covered thing. The only one or two things which probably like got a little missed out is a little focus on the endolaser, which you showed in your there was a video on it. But the thing is that also highlight about the neovascular glaucomas, where of course the anti-VEGFs also cause a very good effect. But when you're doing a vitrectomy and endo-CPC, which can be done to ablate the peripheral ciliary processes to get this down, and also a cyclodiode procedure, which is done in many cases of intractable glaucomas where the person has lost vision, but there's a lot of pain. Those were a few things which got missed out, but all the same, a very good talk.
Dr. Veer,
Thank you for the invite, ma'am. I also agree with the previous panelist. This is pretty much standard now. We use anti-VEGFs and steroids as first line for DME. And yes, at times, even after a few injections, and sursinates is focal laser. But sometimes I've noticed that over a period of time, there are these slight medium-sized troublemaking microaneurysms, which if you add on a little focal laser, they definitely respond much better, and even the anti-VEGF therapy becomes more effective. So for that, that's what I follow. And for PDR, it's a clear-cut PRP is gold standard. I stay away from Protocol S. So yeah.
thank you. Have I missed out on any other panelist? Yeah, I've covered everybody who's present here. Okay, thank you for your thoughts and inputs on lasers in diabetic retinopathy. Moving on to the next talk. Our next speaker is, let me share my screen. Our next speaker is Dr. K. Kalevani, ma'am. She's associated with Vinayaka Mission Medical College, Karaikal. She's pursued her undergrad from Madurai Medical College and then went on to pursue DO at Annamalai University and DNB from Arvind Eye Hospital. And she's also a PhD holder from Annamalai University. Welcome, ma'am. And she's got several years of experience. She's currently the professor and head of the department of ophthalmology in Karaikal Medical College. And she'll be telling us some about masquerade syndromes. Welcome, Dr. K. Kalevani, ma'am.
Yes, madam. Yes, madam. I'm sharing my slides.
Thank you, ma'am.
Good morning, madam. At the outset, I thank All India Ophthalmic Society for giving me this wonderful opportunity. Today, the topic for a discussion is Masquerade syndrome. Coming to the definition, Masquerade syndrome is an ocular inflammatory condition also called as a pseudo-uveitis, which can be caused by a neoplastic or non-neoplastic disease. The name Masquerade syndrome was first coined by Theodor in 1967 for a case of conjunctival carcinoma which presented as chronic conjunctivitis. Currently, it is used for chronic uveitis. According to Martin's dictionary, the word mask generates the verb masquerade, meaning appear in disguise, and the noun masquerade pronounced as masquerade, meaning false show. Certain conditions of anterior and posterior segment can mimic uveitis, and the common finding will be the presence of cells and flare in the anterior chamber. Uveitis masquerade account for about 2 to 5% of the total uveitic patients seen in the referral centers. Usual presentation will be the bilateral involvement affecting the elderly people, presence of aqueous and vitreous cells, history of ocular or systemic malignancy. Most importantly, there will be absence of inflammatory signs like pain, keratic precipitates, synechiae, and these people will be resistant to conventional steroid therapy. This is the list of neoplastic conditions which can masquerade as a uveitis. The primary intraocular lymphoma tops the list. Systemic lymphoma with a metastatic ocular involvement, uveal melanoma, retinoblastoma, ocular metastasis from the lung and breast cancers, leukemia, and ocular reticulum cell sarcoma. So these are the neoplastic conditions. And coming to the benign conditions, juvenile xanthogranuloma of iris, neurofibroma of iris, pigment dispersion syndrome, glaucoma capsulae, anterior PHPV, amyloidosis, retained intraocular foreign body, ocular ischemic syndrome, retinitis pigmentosa, Schwartz syndrome, fundus flavimaculatus, ocular and systemic medications can mimic like uveitis. Coming to the first topic, that is primary intraocular lymphoma. Most commonly, it is a B-cell non-Hodgkin's lymphoma occurring in the elderly individuals of 50 to 60 years, and it's more common in the immunocompromised patients. 80% of this tumor will be bilateral and it carries a high mortality. 60 to 80% of the patients develop CNS disease and it masquerades as uveitis. The primary intraocular lymphoma commonly affects the vitreous and retina, causing vitritis, hemorrhagic retinal vasculitis, and exudative retinal detachment. 20% of the patients may have sub-RPE infiltrates. It may cause central retinal artery occlusion due to the endothelial proliferation of the lymphoma cells in the large retinal vessels. Anterior chamber involvement in primary intraocular lymphoma will be 30%, presenting with the bilateral steroid-resistant either granulomatous or non-granulomatous uveitis. The diagnosis can be by paracentesis or by vitreous biopsy. The vitreous shows elevated interleukin 10 levels, sometimes interleukin 6 levels also, and OCT can detect the infiltrate between the RPE and the Bruch's membrane, and FFA shows blocked fluorescence with the leopard spot. Immunochemistry will be very useful in the diagnosis of lymphomas because they carry surface markers. Basal lymphoma bear CD19, 20, and 22 as markers on their surface, and CD7, 2, 3, 5 are the positive markers for T-cell lymphoma. Recent genetic studies show that there will be translocation of genes in chromosome 14 and 18, especially among the B-cell lymphoma patients. So the treatment for primary intraocular lymphoma is a multidisciplinary approach, most commonly chemotherapy or radiotherapy. Chemotherapy, we give methotrexate either by the intravitreal route or intrathecal route, depending on whether it is ocular involvement or CNS involvement. Then systemic chemotherapy, the drugs are cytarabine and rituximab, which is reserved for recurrent cases. 5-year survival rate in primary intraocular lymphoma is only 3 to 4%, and mean survival is 18 months. Coming to the systemic lymphoma, whether it can be Hodgkin's or non-Hodgkin's lymphoma, it metastasizes more commonly to the eye, and the common site of involvement is choroid, which may present as choroiditis or as a solitary choroidal mass, which may mimic like a choroidal melanoma. Tumor infiltration of the iris can cause anterior uveitis, neoplastic hypopyon in a paradoxically quiet eye. That is very important. We won't have any signs of inflammation. And it can rarely present with the optic nerve head mass and central retinal artery occlusion. The treatment here also, it is chemotherapy and radiotherapy. Here, in addition to the systemic radiation, we have to go for ocular radiations. This slide shows the difference between primary and secondary lymphomas. Primary lymphoma is predominantly occurring in women, usually bilateral, and retina and vitreous are the common site of involvement. There won't be any extraocular extension. And histopathology will show tumor cells with extensive necrosis and numerous mitotic figures. In case of secondary lymphomas, it is predominant in men, it's usually unilateral, and choroidal mass and proptosis are the common manifestations. So here there will be always extraocular extension. And histopathology shows atypical lymphocytes with a high nuclear cytoplasmic ratio and the prominent nucleoli. Coming to the pseudotumor of the uvea, it is a unilateral condition, a relatively benign condition occurring in the older people, present with a multifocal ill-defined creamy choroidal infiltrates. And these can show choroidal thickening. Iridocyclitis, iris heterochromia, glaucoma, and retinal detachment or other ocular manifestations. Paracentesis will help in the diagnosis. Aqueous shows always elevated immunoglobulin levels. And treatment includes steroid therapy plus local beam radiotherapy. Coming to the uveal melanoma, first common site is choroidal melanoma. It is the commonest intraocular malignancy in the adult, occurring in the 6th decade. It commonly involves the posterior pole. It may present as a dome-shaped elevated subretinal mass. It may be melanotic or amelanotic mass. The color may be gray, brown, or orange in color. But if you see orange lipofuscin pigments, it indicates active lesion. It usually present with the posterior scleritis and chronic uveitis, which are not responding to conventional steroid therapy. Coming to the ciliary body melanoma contributes to 10% of the uveal melanoma. Usually we can see a sentinel vessel and a dark pigmented mass behind the iris. It can cause panuveitis and raised intraocular pressure. Then comes the retinoblastoma. Retinoblastoma is a commonest childhood intraocular malignancy occurring before the age of 18 months. And it is one of the most feared uveitis masquerade. Here the inflammation is said to be due to tumor necrosis. Out of the retinoblastoma, we have exophytic, endophytic, and diffuse variety. The diffuse variety is more commonly associated with the pseudohypopyon and it resembles anterior uveitis. When you do the aqueous tap, we will be able to demonstrate the increased LDH level, which may be helpful to diagnose. These are the pictures associated with the retinoblastoma, with the leukocoria, pseudohypopyon, and with the uveitis. Then the metastatic carcinoma, here the primary site may be the lung or the breast, usually involve the choroid, presenting with the bilateral choroiditis. Multiple gray-yellow lesions may be associated with the exudative RD. This is a picture showing the choroidal mass with the exudative RD secondary to the lung cancer in a 70-year-old man. And this is an anterior segment infiltrate secondary to the breast cancer patient. Iris and ciliary body can also be involved presenting as anterior uveitis. Horton et al. In American Journal of Respiratory and Critical Care Medicine reported a case of adenocarcinoma of lung presenting with the vitritis and snowball. Then comes the leukemia. Leukemia, ocular manifestation in leukemia is 75%. It can affect both anterior segment as well as the posterior segment. In anterior segment, it can present with the iritis, with the diffuse or nodular iris thickening and a pseudohypopyon, with the consisting of the tumor cells. It can also cause vasculinitis. Coming to the posterior segment, it involves the retina, causing white-centered hemorrhages, that is rot spots, perivascular infiltration, retinal hemorrhages, and exudative retinal detachment. RD may be due to the choroidal infiltration and the consequent ischemia. The last one in the malignant list is your ocular reticulum cell sarcoma. It is also called as primary CNS lymphoma. It's a rare type of lymphoma affecting the eye, frequently accompany or precedes the CNS involvement. The tumor infiltrates the retina, causing retinochoroiditis, vitritis, and exudative retinal detachment, sometimes with the glaucoma. Vitreous aspiration and MRI confirms the diagnosis. The tumor is radiosensitive. Now coming to the benign lesions that can masquerade as uveitis. First one is the juvenile xanthogranuloma of iris. It is a yellow, fragile, poorly demarcated iris tumor with a spontaneous hyphema simulating uveitis. It is a tumor occurring in the infant or children less than 2 years of age. Common age of occurrence is first year of life, and it is very rare in adults. Iridectomy or iridocyclectomy are the treatment options, and spontaneous resolution is also sometimes possible. Neurofibroma of iris. This is associated with the neurofibromatosis type 1. Here you can see the leash nodules. The leash nodules are raised tan-colored nodules, which may be mistaken for Buschaka nodule in granulomatous iridocyclitis. Now coming to the pigment dispersion syndrome. Pigment dispersion syndrome commonly masquerade as anterior uveitis because the pigments are dispersed over the corneal endothelium, trabecular meshwork, as well as in the anterior chamber, may be misinterpreted as inflammatory cells in anterior uveitis. Here we are seeing the Krukenberg spindle, which may mimic like a keratic precipitates. Then the glaucoma capsulae. Here it's a pseudo-exfoliation of the lens capsule. Bluish white or the gray color flux seen in the aqueous may mimic like anterior uveitis, but the characteristic 3-zone layer over the anterior capsule will help to arrive at the diagnosis. We can see a central translucent zone, intermediate clear zone, and a peripheral membrane. Most important when the benign lesion is anterior primary hyperplastic posterior primary hyperplastic vitreous. Here the patient present with the microphthalmos, dilated iris vessels, elongated ciliary processes, and abundant fibrovascular membrane covering the lens. This may be mistaken for chronic uveitis with a complicated cataract. Then amyloidosis. Amyloidosis, suppose if you see a patient with a without any inflammatory signs, but iritis is there, look for if you see a vitreous opacities, the cells are larger than the inflammatory cells, then think of amyloidosis. So it contains only absence of inflammation and the globules in the vitreous, anterior vitreous, showing the amyloid bodies, which may be cellular, membranous, or wheel-like. The condition can be diagnosed or confirmed by vitreous biopsy. Then comes the intraocular foreign body. Long-standing intraocular foreign bodies, copper or iron foreign body, can present with the uveitis. Copper foreign body causes intensive acute anterior uveitis, and iron foreign body or siderosis causes anterior or intermediate uveitis. In siderosis, we can see the characteristic rust spot over the iris or beneath the anterior lens capsule. These are all the rust spots. Now, the ocular ischemic syndrome, 20% of the patients with ocular ischemic syndrome may have the inflammatory cells in the anterior chamber. They can have the keratic precipitates and posterior synecdoche also. Iridocyclitis, neovascularization on the iris, and neovascular glaucoma are the common anterior segment manifestations. Then retinitis pigmentosa also can be mistaken for uveitis. Datta and Mania et al. In their study of about around 8,000 patients about retinitis pigmentosa, they showed that 22 patients presented with the intermediate and posterior uveitis. They said the immune-mediated damage secondary to the death of photoreceptors may be the cause of uveitis. The patient present with the vitreous cells and cystoid macular edema. Then coming to the Schwartz syndrome. Schwartz syndrome is a rare condition which is characterized by the rhegmatogenous retinal detachment and presence of cells in the anterior chamber with the raised intraocular pressure. Electron microscopy of the anterior chamber fluid, it shows the presence of outer segment of the photoreceptors. Sometimes this Schwartz syndrome can present with the exudative panuveitis with the intensive anterior chamber reaction, especially when the RD is associated with the Wach-Haina-Harada syndrome or trauma. Then the macular cause, fundus flavi maculitis. Here the pathology is with the retinal pigment epithelium. The retinal pigment epithelium fails to phagocytose the outer segment of the retinal photoreceptor. So there will be accumulation of yellow lipofuscin-like substance at the level of RPE, which may be confused with the disseminated choroiditis. Now, there are some drugs which can cause or mimic like anterior uveitis. This may be either topical, systemic, or intravitreal preparations. That is, triamcinolone acetate molecule can migrate anteriorly and produce sterile endophthalmitis with a pseudohypopyon. Then among the anti-VEGF, ranibizumab, bevacizumab, after 1 or 2 injections can cause transient anterior uveitis, but the incidence is very low. Cidofovir antiviral drug can also cause non-granulomatous uveitis. Coming to the topical preparations, brimonidine causes granulomatous anterior uveitis. Metoprolol and prostaglandin analogs can cause anterior uveitis. Coming to the systemic drugs, rifabutin, which is an antiviral HIV drugs, sulfonamide and diethyl carbamazine can cause non-granulomatous anterior uveitis. Now, this is a flow chart of what we have seen so far. If you see a patient with a Masquerade syndrome, think of neoplastic as well as the benign conditions. In malignancy, it may be either hematological or solid. If it is hematological, it can be either lymphoma or leukemia. If it is a solid, it can be a primary tumor or a metastatic tumor. If it is metastatic, the primary may be either in the lung or in the breast. And non-neoplastic condition, there are many conditions which we have seen before. So the take-home message is masquerades represent the uncommon presentation of rare disease. Patients with a neoplastic masquerade will be always elderly people with a unilateral posterior segment inflammation, posterior visual acuity compared to the conventional uveitis patients. Rule of thumb about the steroid-resistant uveitis described by Dr. Whitcup gives a clue about Masquerade syndrome. These are my references, and thank you.
Thank you so much, ma'am, for covering most possible causes of Masquerade syndrome, covering almost everything extensively. My question to the panelists here is sometimes the vitreous biopsy can be challenging in terms of getting the sample to the place at times if the cells are very labile. So in our setup, most places it is sort of difficult. Do you look at any clinical or rather imaging biomarkers, like in a case of probably primary intraocular lymphomas and other things that probably would help us in our clinical practice to narrow down differentials? I'd start with Dr. Karobi Lahiri. Ma'am, what are your thoughts on the challenges in masquerades?
This is a very challenging situation, and Dr. Kalaivani has really extensively covered it because it's such a huge topic. It is a topic which is important because you have many of these situations where you do not know where to go ahead, and masquerades is one thing which you have to bear in mind because many a times it turns out to be this. The most important way is that, okay, if you go and do a vitreous biopsy, get a sufficient material, see that you don't dilute it with any kind of fluid, take a sample which is concentrated and send it for your for the investigation. But the OCT and OCTA also, these are good parameters to know what is happening, because you know what is happening to the underside of the retina and the different layers from which layer it originates. And sometimes an FFA also can give you some kind of markers. So we would like to do these investigations as well in these cases, unless the view is so bad that it doesn't permit this investigative facility. So I think we would cover it up with all these kind of things. Like I've had a case, so she's a patient of CAR. Now that is a carcinoma-induced retinopathy. She was given an anti-VEGF for ARMD. She responded for the first 2 injections. The 3rd injection, she developed an inflammation on the 14th day. We thought it is related to the anti-VEGF, but giving her steroids for a very long time, she has not responded. So the thing is that we went ahead and we did a small biopsy and we sent it, and she has got a positivity in the IL-6. She had a carcinoma of lung long back, which was treated. So I think this is a carcinoma-induced retinopathy just now, and not so much the ARMD, which is playing up, So these masquerades are all like this, and you have to always think out of the box if you don't get a favorable response to whatever treatment that you're suggesting or doing for them.
Thank you, ma'am. Truly, it is a challenge and an absolute googly in terms of sometimes to understand where it is coming from. I'd like to ask Dr. Jatinder Singh, sir, what are the challenges that one faces, and in terms of diagnosing it, narrowing down? Please share your thoughts, sir.
Very well put up talk by Dr. Kalevani. I think these cases don't come with a label. And in the routine OPD, when we are seeing a lot of other bulk cases, some of these cases will just pop up and will present a significant challenge in terms of diagnosis and then later on management. Regarding primary intraocular lymphoma, any elderly patient presenting with unexplained uveitis, usually a relatively white eye and bilateral presentation, the alarm should, it's a red flag sign that this patient is probably harboring some neoplasm. So in those cases, get an OCT done. And since vitreoretinal lymphoma can involve vitreous, anteretina, posterior retina, and sometimes choroid also in the anterior choroid, it is very difficult to pinpoint and say like, okay, this is primary intraocular lymphoma or it is not. But there are certain features, especially when you see hyperreflective focal lesions in the outer retina, especially more commonly than anterior retina. And they are usually, they can sometimes be present on the retinal surface only. So it's a challenge to diagnose it. But I think keeping a very low threshold to do a biopsy is what will clinch the diagnosis and make it irrefutable, and would actually avoid a delay in the diagnosis and proper management of the patient. And whenever you have to do the biopsy, one key thing is to stop the steroids at least 2 weeks prior, so that the cell harvesting is good and the chances of getting a good report, a positive report, is elevated. And while doing biopsy, again, few points, you have to use a low cut rate because these cells are fragile. Low cut rate, high suction, and first is just aspirate in the syringe, and then in the cassette as well can be sent for centrifuging and for histopathology assessment. IL-6, IL-1 has actually made it a little simpler, but histopathology again still would remain the gold standard to see these cells, abnormal cells, and identify them. When I thought your question was related to primary intraocular lymphoma, or was it in general?
Primary, most commonly seen primary intraocular lymphoma, because that almost always poses a challenge to most of. Thank
you. If you feel that the report has come negative and you still strongly believe that in the clinical judgment, you have to press to the neurophysician, probably do a CSF tap and repeated MRIs whenever needed. I have lost one patient where I was not persistent enough though I thought it was clinically primary intraocular lymphoma, but the physician was treating for sarcoidosis. So that is something which I have burnt my hands with.
Also, the interleukin 10 by 6 ratio can also be very helpful. So it's always a mixture of clinical imaging, and the earlier the better vitreous biopsy that probably can help us identify it earlier and probably treat it appropriately. Dr. Abdul Waris, sir, what are your thoughts, sir, about masquerades and what are the challenges that you faced in your vast experience?
Yeah, I will come to your question. First of all, one comment I would like to say, just add on. In cases of HIV patients, those who are on a heart therapy, sometimes there is a rebounds of uveitis. That is also a part of masquerade syndrome, very commonly seen. And the talk was excellent. Now, coming to your question of intraocular lymphoma diagnosis, I think for me, no OCT, no biomarkers can be specific. See, interleukin 10, what ratio you are talking, is not specific for ophthalmology, only for eye. The only thing is that vitreous biopsy. There is no substitute to that. And you have to send it for histopathology and for markers now. As sir told, the cut trace and all, sir has already mentioned. You can take help of your CNS doctor who can do a CSF tap and probably give you some additional information. But specifically for intraocular lymphoma, only involving the eye, I think there is no substitute for vitreous biopsy, and definitely it's a challenge for us. Thank you.
Thank you so much, sir. Dr. Veer, what are your thoughts on diagnosing, understanding masquerade and
So, one second. So I'm on similar lines with other panelists. So, but I feel yes, because of the new imaging modalities, we should use them as much as possible with the OCT and the angiographies, and not specifically for intraocular lymphoma, for even ultrasounds for melanomas. So all our clinical examination, clinical judgment, patient history, patient profile, these definitely have an important role. And further, we should involve neurologists and say radiologists to get all the imaging done. But yes, for coming to PVRL, then again, once we've figured out, narrowed down to PVRL, a vitreous biopsy needs to be done. And whatever time you're wasting that. So you go with your clinical acumen, take the help of all the investigative modalities you have, get a general scan, if a PET scan and all these things are required. But then eventually, yes, you have to do these things in a timely manner so that you don't lose precious time.
Thank you so much. Dr. Girish Rao, sir, I'd like to know your thoughts about the challenges that one faces in diagnosis when you're faced with a masquerade syndrome, and how useful are imaging biomarkers like, say, an OCT, wherever possible, to help you probably narrow down to fewer differentials.
Yeah, so I think whenever you face a patient who does not fit into any particular slot, that's when your antenna should be up, that you're probably looking at something which is masquerading, and especially if you have conditions like a lymphoma or a leukemia, which can affect multiple layers, you really should know that you're probably dealing with something much more than specifically to the eye itself. And as the other panelists said, you need to be very diligent with investigations. Now, the one of the points with lymphoma is they respond very well to steroids initially. So any patient who responds but then recurs whenever there is, your antenna again should be very high, and you probably need to have a low threshold for going in for doing the biopsies. Regarding the investigations, the FFA especially might show the leopard spot findings, especially if there are infiltrates within the choroid, which will show up as hypofluorescence. In the choroid, on the OCT, you will see the undulations in the subretinal space and the choroidal thickening. So basically, you might have to pick up multiple points from the clinical, the investigative modalities, and also rely on the physicians or a neurophysician or any other super specialty findings to come to a diagnosis. And obviously, the sooner you diagnose, you might actually pick up this primary intraocular lesion or a secondary due to a systemic tumor much earlier and get down to the appropriate treatment. So, just a word about there is also a role of genetic analysis in lymphoma. So, in case there is still a diagnostic dilemma where you strongly feel but all the other modalities come negative, genetic testing, especially for MYD88, might actually clinch the diagnosis, and so that an appropriate treatment can be started earlier for such cases in case of a lymphoma.
Thank you. How relevant do you think is cytokines and immunophenotyping in these kind of cases?
These are definitely relevant. So, in addition to just the histopath, I think the immunohistochemistry and all these cytology and cell fluorometry, all these have a lot of relevance, and especially in primary intraocular lymphomas, the IL-10 by IL-6 ratio, especially if it's skewed completely towards the IL-10, is a very strong indicator of lymphoma. So, yeah.
Thank you so much, sir. Thank you so much, ma'am, for a wonderful, extensive talk. Moving on to our next speaker. Our next speaker is Dr. Swati Shri Naik, ma'am. She is currently the Associate Professor in Ophthalmology at All India Institute of Medical Sciences, Guwahati. Her MBBS is from Sambalpur University, MS from Cuttack. She went on to pursue a fellowship in pediatric ophthalmology and strabismus from Arvind Eye Hospital, Pondicherry. And her professional skills or areas of expertise include strabismus surgery, SICS, phaco, pediatric ocular surgeries, and she's been a teacher, mentor to so many students. And today she'll be talking to us about ocular stem cells. Ma'am?
Yeah,
Welcome.
I'll just share my slide. So, okay. Okay, is my screen visible?
Yes, it is.
Right. So at the very outset, I would like to thank AIOS for giving me this opportunity to talk on ocular stem cells today. A very good morning. This is the place where I work. Now, at the very outset, I would like to tell you how a cell would look like. So the cell, which is the basic structural and functional unit of life, and here every cell, it contains the cytoplasm within the membrane, and there are many organelles, but these organelles and the cell in total has a specific function. Now, coming to the stem cells, the cells in our body, they have specific purposes. But when we talk about the stem cells, they are the cells which do not yet have a specific function, and they can become almost any cell that is required. So these undifferentiated cells that can turn into specific cell as the body needs them are called as stem cells. So the stem cells are the cells with the potential to develop into many different types of cells in the body. They serve as a repair system for the body, and that is why the scientists and doctors, they are very much interested in the stem cells as they help to explain how some functions of the body work and how sometimes they can go wrong. So these stem cells, they show a promise for treating some diseases that currently have no cure. Now, how the stem cells are different from other cells in the body? It is basically by three ways. First is they can divide and they can renew themselves over a long time. They are unspecialized, so they cannot do specific functions in the body. And most importantly, they have the potential to become specialized cells, such as muscle cells, blood cells, and brain cells. Now, the basic characteristics of a stem cell are, first of all, it can self-renew. And the second is, it can differentiate into specialized cell type. Now, when there is a fertilization of the sperm with the egg, it forms a zygote. The zygote in turn forms the morula into the blastocyst. Inside the blastocyst, we have the inner cell mass or the embryonic stem cells, which has the capability of self-renewal, and also it can specialize into the 3 germ layers of ectoderm, mesoderm, and endoderm, which in turn give rise to the other cells or organs of the body. Now, what is important to when we classify the stem cells? What is important to know is the potency of these cells or their ability to divide. As we know, the totipotent and pluripotent are embryonic stem cells. So let us understand what this totipotent and pluripotent means. In totipotent cells, the stem cells in the zygote and in the first few divisions of the zygote are totipotent. So by totipotency, we mean that they can differentiate into embryonic as well as extraembryonic cell types. But when we talk about the pluripotent, the blastocyst, especially the inner cell mass of the blastocyst, it can differentiate into all the cells of the body derived from 3 germ layers, and they are called as your pluripotent. So these pluripotent cells, they can either be embryonic stem cells or you can induce these pluripotent stem cells. Now, the adult stem cells can either be multipotent, they can be oligopotent, or they can be unipotent. So by multipotent, we mean that if they can differentiate into numerous but closely related cells. For example, we have the hematopoietic stem cell, and that can differentiate into your RBCs and WBCs. So when we come to the term as oligopotent, it is slightly different in the field that it can differentiate into only a few cells. So for example, you have a myeloblast. So it can differentiate into your 3 types of WBCs like eosinophils, neutrophils, and basophils. On the other hand, unipotent is one cell type. It can divide into only one cell type. For example, your germline stem cell, and that produces only the sperms. Your epidermal stem cell, and that produces only the skin. So this was about a diagram to show your totipotent embryonic stem cell, your pluripotent embryonic stem cells, and your multipotent stem cells. These stem cells have the remarkable potential to renew themselves. They can develop into many different cell types in the body during their early life and growth. There are several main categories: the pluripotent stem cells, embryonic and induced pluripotent stem cells, and non-embryonic or somatic stem cells, commonly called as the adult stem cells. The embryonic stem cells have the ability to differentiate into all the cells of the adult body. On the other hand, the adult stem cells are found in a tissue or an organ, and they can differentiate to yield the specialized cell types of that tissue or organ. Now, if we could see, the blastocyst has an inner cell mass, and this is from where we get the embryonic stem cells. They get the differentiation signals and they can develop into these 3 germ cells. On the other hand, if the blastocyst gets a chance to develop and it forms an adult, then we have the somatic stem cells, and when they get the differentiation signals, they can develop into cell types which is restricted to the organ cells. So basically the stem cells would be lying quiescent until and unless they get some growth factors. So these are the embryonic stem cells here present here in the inner cell mass, which can develop into RBCs, fat cell, cardiac muscles, enterocytes, chondrocytes. These are your induced pluripotent stem cells. That is, the embryos can be taken, the isolated inner cell mass can be taken out, and it can be cultured, and then what we can get is your established embryonic stem cell culture. Again, we have adult stem cells, but unlike the embryonic stem cells, these are stored in the body to replace the dead or damaged cells in the skin. For example, the skin has a large reserve supply of skin stem cells, and they multiply only when it is needed. So to summarize, the embryonic, we have basically 2 types of stem cells, the embryonic stem cells and adult stem cells. Embryonic is basically in the inner mass of the blastocyst, or it can be grown in the culture, and they are pluripotent in nature. On the other hand, the adult stem cells, these are the various tissues in the adult, these are multipotent, they are difficult to isolate and maintain in culture. So coming to specifically the ocular stem cells, in this diagram of the eye, the blue squares, they are representing where we harbor our stem cells in the ocular system. Basically, they are present in the limbal stem cells, the ciliary marginal zone, and the retinal stem cells. So that is why, because of this, the presence of these stem cells, we have our targeted ocular tissues and the disease conditions that they can cure. So if it is the corneal stem cells, it can be limbal stem cell disease, the dry eye disease, bullous keratopathy, and mostly in the retina, the age-related macular degeneration, Stargardt disease, retinitis pigmentosa. Now, regenerative medicine or stem cell-based therapy has now reached a state where ocular tissues damaged by disease or injury can be repaired or regenerated. Ease of access for the therapeutic procedure as well as follow-up makes it even more interesting. And even more important is the immune privilege status that the eye has, which makes it an ideal organ. Such therapy, it involves various procedures where the stem cells are injected into both the cellular and extracellular matrix environments. Now, what makes the eye an ideal organ is because of the presence of these ocular barriers, which comprises of the blood aqueous barrier as well as the blood retinal barrier. Now, in this blood aqueous barrier, we have the non-pigmented ciliary epithelial cell of the ciliary body and the endothelial cells of the iris blood vessels. The blood retinal barrier has two types, the outer blood retinal barrier and the inner blood retinal barrier. The outer blood retinal barrier comprises of the retinal pigment epithelial cells, whereas the inner blood retinal barrier has the choriocapillaries. Now, the first place where the limbal stem cells has in the eye where it is present and which has got a very significant importance is your limbal area. So here, if you see the limbal epithelial stem cells, so these stem cells, they are located in the corneal epithelium in the basal layer of the limbal region at the corneal periphery. So they are called as your palisades of Vogt. And these are visualized in small clusters and they are closely associated with the stromal matrix. So the corneal epithelial basal layer, it is composed of the transient amplifying cells at various stages of maturity. Now here is the XYZ hypothesis of the corneal epithelial membrane, which was given by Vogt and friend. So here X represents the replacement of the striated cells from the corneal surface, which is proliferation and migration of the basal epithelial cells. Y is the centripetal movement and Z is the cell loss from the corneal surface, and X plus 5 remains Z. So these are the some cases of limbal stem cell deficiency, which leads to conjunctivalization of the cornea. So there is a loss of the deficiency of stem cells in the limbus. The stem cells are vital for the repopulation of the corneal epithelium and barrier function of limbus. And when these stem cells are lost, the corneal epithelium is unable to repair and renew. That results in epithelial breakdown. It results in persistent epithelial defects, corneal conjunctivalization and neovascularization, scarring, and also chronic inflammation of the cornea. Now, there are several surgical techniques for limbal cell transplantation, which have been described for a successful limbal transplantation, namely the conjunctival limbal autograft, the keratolimbal autograft, the cultivated limbal epithelial transplantation. So this was this SLED technique, which was simple limbal epithelial transplantation. It was first described by Dr. Sangwan in 2012, where it is a reproducible single-stage technique, which does not need any laboratory setup. It is a more conservative for donor eye. So basically, they take out the donor's limbal stem cells, they put an amniotic membrane graft with the vestment membrane up, and then they make the pieces of the limbal stem cells, they put it on there with the epithelial side up, and the last picture shows how it looks after the slit. Now, I would like to more focus on the retinal stem cells in particular. So why the retina? The retina is an ideal anatomical location for cell transplantation, as it is relatively simple to access and monitor and requires relatively few cells to achieve a therapeutic effect. Furthermore, the eye is an immune privileged site with a reduced risk of graft rejection. The graft function can also be assessed using several non-invasive techniques such as optical coherence fundus, autofluorescence, fluorescein angiography, and visual field tests. Now, the various sources of retinal stem cells are, it can be either endogenous retinal stem cells like neural stem cells, Muller cells, pigmented ciliary margin zone. It can be other somatic derived stem cells like the bone marrow mesenchymal stem cells, the adipose derived stem cells, or it can be embryonic stem cells and induced pluripotent stem cells. So they differentiate into specific retinal pigment epithelial cells, and that can again be transplanted. So these are the, this is a picture showing how it looks in the healthy retina. So if you see in the healthy retina, in the macula as well as in the periphery, it has meso cells of retina, and there is a clear distinction between the photoreceptors of macula versus the peripheral retina. But when we come to age-related macular degeneration, in the intermediate stage, the subretinal pigment epithelium, it shows drusen's deposits and early signs of retinal pigment epithelial dysfunction. In the advanced stage, there is a loss of retinal pigment epithelial cells as well as cones in the macula as well. In retinitis pigmentosa, in the intermediate stage, there is progressive degeneration of the rods in the peripheral retina. In the intermediate stage, there is partial loss of rods, whereas in the advanced stage, there is widespread loss of rods in the peripheral retina. Now, the therapies for retinal degenerative diseases are the stem cell-based therapies, progenitor cell-based therapies, and gene-edited cell therapies. We would concentrate on the stem cell-based therapies. This is an overview which shows how the cell therapy transplantation and the outcome that we can achieve in the retinal degenerative diseases. So in the early stages of age-related macular degeneration, the cell therapies, they aim to preserve the cone photoreceptors by transplanting RPE cells. But in the advanced stages, transplantation of both RPE and cones may be required to restore vision, while other retinal degenerative diseases may require the transplantation of rods and cones as well. The possibility of photoreceptor integration that depends on the structural and functional preservation of the remaining retina, particularly the outer nuclear layer and the retinal ganglia, to process and transmit visual information to the brain. To achieve this retinal integration, the donor cells are transplanted into the subretinal space above the RP layer, and that must then migrate and extend processes towards the host outer nuclear layer while overcoming the barriers of outer limiting membrane. Subsequently, the photoreceptors must mature and function normally through interactions within the surrounding retinal environment. So from where the stem cells can be obtained, they can be from the donor retinal tissue, the RP cells, they are directly obtained from the donor's retina. The induced pluripotent stem cells, they are reprogrammed adult somatic cells which are differentiated into RPE-X50. Human embryonic stem cells, they are derived from the inner cell mass of the blastocyst and they differentiated into RPE. So if you compare between the induced pluripotent and the human embryonic stem cells, the induced pluripotent, their source is reprogrammed adult somatic cells. They have fewer ethical concerns. The differentiation requires reprogramming and they are more readily available. On the other hand, the human embryonic stem cells are obtained from the inner cell mass of blastocyst. They have multiple ethical concerns. They require differentiation and they have limited availability. So the embryonic stem cells, they are pluripotent and they're derived from the early stage embryos. They have the capacity to differentiate into any cell type, including the specialized retinal cells such as photoreceptors, RP cells, and retinal ganglion cells. Versatility is what makes them different, and that makes it a vital tool as well in regenerative medicine, notably for treating the complex retinal degenerative diseases like ARMD and RP. Although they are very adaptable, but they're transplanting them into patient, it also carries the risk of immunological rejection and ethical issues. The patients need to be on long-term immunosuppressants, which carries its own risk of problems, including the greater susceptibility to infections and other immune-related conditions. On the other hand, if you see this induced pluripotent cells, they are generated by reprogramming the adult somatic cells to this pluripotent state. So since they are generated from the patient's own cells, the risk of immunological rejection is reduced, and that avoids ethical concerns. The other advantage is they do not need so much of immunosuppressants, and we can stimulate they can be used to stimulate retinal diseases in lab. Researchers can also understand the underlying mechanism of these disorders and create novel treatment approaches. So the first picture shows the healthy retinal tissue. The second shows the diseased retinal tissue, where we can see the loss of the RP as well as the photoreceptors, and then how we are going to introduce the RP, like as in a cell suspension or like a RP monolayer or with the scaffolds. So coming to the surgical procedure of that, first of all, we can make a pars plana, the current subretinal transplantation modes of RP implants. First of all, we need to remove the vitreous humor from the eye by a 3-port pars plana vitrectomy. So the 2 ports are to implant the surgical instruments and a light source. The 3rd port is to inject fluid and to keep the eye pressure constant. Next, a bleb is created by separating the retina, and the saline solution is injected in the subretinal region. So we can deliver the scaffold-free implants into the bleb, which may be in the form of cell suspension, cell strips, or cell sits. Otherwise, we can also use scaffold-based RP implants, which may be unfoldable or foldable RP patch into the subretinal space via an enlarged retinotomy made in the bleb area. Now, in this, the surgical challenges that one may face is in eyes with large areas of geographical atrophy. There would be strong adhesive forces that impedes this bleb formation, and the scaffolds, they can lead to larger. We need larger incisions to introduce those, and that can in turn cause hemorrhages and PVR changes. So if it is in the late stage of disease with a photoreceptor loss, it may need both photoreceptor and RP replacement. So and of course, it is important to preserve the neural connections between the bipolar and ganglion cells as well. So these are some pictures where it shows the scaffold free, where we use the cell suspension, the cell seats, and the scaffold based materials that can be used for the RP implants. The scaffold-free RP implants can be cell suspensions which are prepared immediately before surgery and they're injected subretinally. It can be cell sheets, which is a monolayer, or it can be cell strips which can be formed over 2 days on a specialized device. Now, the advantages of the scaffold-free implants are that no foreign material is induced. It needs a smaller incision, it minimizes complication, and there is a faster recovery. And if you have challenges are, if it is an aged or thickened Brooks membrane in AMD patient, that hinders the integration, achieving the consistent monolayer, and optimizing the cell strip deposition and preventing multi-layering. The advantages of scaffold-based are it can provide the extracellular matrix support for RP engraftment. It can facilitate the functional integration at the AMD lesion site, and it has demonstrated effectiveness in preclinical models. That it transplants a functional RP monolayer on an artificial basement membrane with normal morphology, orientation, and function. But the various challenges are it requires more complex implant preparation with biocompatibility assessment and the functionality and polarity checks. Some additional time is needed for material fabrication and RP cell culturing, depending on the scaffold topography and material. The potential complications can be disrupting the retinal oxygen permeability, hazardous degradation products, and the inflammatory responses since the size of the incisions is also increasing. So the various modes of delivery, how we can deliver this is injection by the fluids. It is the most common and direct method. It is used for the scaffold-free implants. The RP material is drawn into the cannula and it is injected subretinally with fluid assistance. So it requires the smallest retinal injection by a micro injection device. We can use the pushing by plunger technique, where a plunger is used to push RP graft into the subretinal space. It can be a foldable insertion where forceps-like device is used to insert the scaffold-based graft. The advantages are it can deliver relatively larger implants, but it is definitely a more complex technique. So in one groundbreaking study, Sasai and his collaborators they developed a protocol for obtaining eye cup-like structures in vitro, and that was called as the organoids. So these retinal organoids are 3D tissue structures which are derived from the embryonic stem cells or the induced pluripotent stem cells in vitro, and they characterize the structure and retinal function to a conveniently important extent. So since 2011, mouse and human retinal organoids have been made available, opening new avenues for retinal development, disease and regeneration research. Over decade, a great progress has been made in development of these retinal organoids, which is reflected in improvement of differentiation efficacy and development degree. Now, how it is made is, once we take these embryonic stem cells or induced pluripotent stem cells, they were dissociated and they are reassembled in a serum-free and low growth factor medium. So they can be forced to form an embryonic body. The matrigel is added and stimulated to differentiate into neuroepithelial cells and subsequently retinal progenitor cells and double layer optic cup structures. The second differentiation method is the stem cells were divided into small pieces to form aggregates. These aggregates were cultured on matrigel or floated in the form of cups, lumps. After differentiation into neuroepithelium and optic vesicles, retinal organoids were formed. So coming to the recent trials in age-related macular degeneration, most clinical trials to data, they have used embryonic stem cells due to the significant barriers to induce pluripotent stem cell-generated RP cells. The use of patient-derived induced pluripotent stem cells for autologous cell replacement in clinical trials poses different challenges because there is a lack of suitable clinical manufacturing process and differentiation of multiple patient cell lines. So there have been concerns about reprogramming of the somatic stem cells, and that can introduce genetic alterations in oncogenes and tumor suppressor genes. So clinical trials to date have overall demonstrated safety of transplanting stem cell-derived retinal pigment epithelium. Now, one landmark trial which is always mentioned, is the stem cell ophthalmology treatment study, or the SCOTS trial. So it is an institutional review board registered, and it has been monitored. The human clinical study, which utilizes the autologous stem cells from patients' own bone marrow. This study is listed on National Institute of Health Clinical Registry website. So it assesses the effect of bone marrow-derived stem cells on dry age-related macular degeneration and other retinal and optic nerve diseases. So what they did is they took 32 eyes for treatment, and they could see an improvement in visual acuity in 20 of the patients. Now, some of the barriers that we face are the integration of the transplanted photoreceptors into existing neuronal circuits. Novel methods for re-establishment of the native rod and cone mosaic may be necessary to optimize the visual acuity. Additionally, there are functionally diverse subtypes of bipolar neurons, and the rods in the newly formed rod and cone mosaic will need to appropriately align with the existing retinal circuit architecture. Now, why not retinal ganglion cells? Retinal ganglion cells, they must reach specific locations within the retina and synapse with other neurons in the retina to form circuits. There are 30 specific subtypes of retinal ganglion cells, and each has its own unique function in vision, at least in part by the cell circuitry within the retina. The second point is, after achieving the integration and functional connectivity with afferent neurons in the retina, the transplanted retinal ganglion cells need to regenerate their axons and extend to the CNS targets which is very necessary for visual perception. Moreover, reconstruction of visual space depends on the specially organized actional projections of the ganglion cells to form a retinotopic map. So in retinitis pigmentosa, this was a study which was published in Cell Stem Cell by Hirami et al. From Japan. So what they have done is induced pluripotent stem cell derived 3D retina. They have dissected it into three parts, the retinal organoids into three parts, and then they have, with the creation of a blade, they have tried to implant it. So after that, what they find is that it was done in 2 patients, and the highlights were in the allogenic induced pluripotent stem cell derived retinal organoid seeds, which were transplanted in 2 retinitis pigmentosa patients. The graft survived without immune rejection or tumor formation for 2 years, and response to full field light stimulus was possibly improved in 1 of the 2 patients only. So finally, to conclude, stem cell-based therapies offer a promising approach for treating retinal degenerative diseases. Early clinical trial data indicate safety and potential efficacy. However, further research is needed to optimize the manufacturing process, the delivery methods, and long-term integration of these transplanted cells. The success of these therapies relies on addressing the challenges related to immune rejection, tumorigenicity, and surgical considerations. With ongoing advancements in stem cell technology and surgical techniques, stem cell-based therapies have the potential to revolutionize the treatment of retinal degenerative diseases and restore visual function of affected individuals. Thank you.
Thank you so much, ma'am, for this extensive talk about ocular stem cells, and it is truly a futuristic things, and there are so many unanswered questions in it. What I would like to know from our panelists here is, how is it feasible? I mean, all the studies that we've seen so far, how can we use it in an Indian cohort, and how feasible it is in our population? I'd like to start with Dr. Jatinder Singh, sir.
Yeah, very well put up talk. It was like listening to an embryology lecture from the first year of MBBS. So, but the teacher was just better. Thank you so much. I think there are a lot of challenges on this stem cell research, though it has started almost like 25, 30 years back. But the real focus has started only maybe like half a decade ago. Earlier, we were just thinking about gene therapy being the thing of future. But I think stem cells would have a better chances of getting to treat these so-called non-treatable diseases. I think the challenges are many. One is when you reduce the antigenicity, then the chances of tumorigenesis is high. So there has to be a very delicate balance between the two. That it should not be antigenic, and it should not in the long term cause any tumor related issues. So we will probably take more and more allogenic or autologous tissues and make stem cell therapy out of that. The second is that the longevity of these stem cells is something which has not stood the test of time. We have had good results for 2 months, 3 months, 6 months, but by the end of 1 year, most of these therapies have not shown anything better than the natural course of the disease. There are few now which have shown a 2-year data also, and they look promising, but we will have to still wait and see how they will hold on. The other thing is about the cost implications. I think a lot of research is going on, and this cost is going to be prohibitive, at least in the initial period. And because the cost is, the finances are involved, there is also a lot of greed, and there are a lot.
Fatima, can you please stop this presentation, please? Stop share, please.
And because of the finances involved, there is a lot of greed and a lot of unethical practices. And we've heard few incidents happening even in the Western world, where people had complications because of the so-called stem cell therapy from quacks. So though all these issues put together, it is still a challenge. But I'm hopeful that in coming years, maybe another 4-5 years down, we might have something more concrete and which will really help us out. I think one key will be to hold on for the longevity is to couple two adjacent stem and cells like RP cells and photoreceptors can be coupled and given together because they will hold better for long term. Just giving single RP cells, single photoreceptors is not going to work. The other thing is to probably go a little downstream and get the middle retinal cells take up the function of photoreceptors also. So all these things are, I think, the basic scientists are looking into, and they will bring something to us. Thank you so much for your excellent talk.
Thank you, sir. So yeah, various cells, again, bigger the challenge is them integrating with the host cell and then forming a network, because more the cells, more will be the challenge also. Different type of cells, again, getting polarized or integrating to the host cell, again, becomes a difficult challenge. Also, if it is unchecked, or the division of it, or that also leads to this factor of tumorogenicity, like you said, sir. So, Dr. Karobi Lahiri, ma'am, where do we stand in terms of the ethics part of it, or the legality of it in our country as of now, as far as stem cell therapy is concerned? Are we prepared fully, or how is it? What are your thoughts, ma'am? Please unmute, ma'am. We cannot hear you.
Thank you. See, this is a topic which is very controversial, and it is something which most of us don't know much about. Okay. Now, listening to Swati Shri was like having a real good class, and trying to understand what the stem cell therapy is. Because what happens is that we've heard that, it works well for the cornea, it works well. They have been trying it for the RP cells and the photoreceptors for the retina and all. But have we really integrated this into our patient population? Most of us have not, except a few centers where they are doing this properly. Now, the thing is that when coming to the legalities of these things, this much I know, that if you have to integrate these stem cells into patients, you have to have the proper stem cells to give the proper desired effect. If there have been cases where they have been injecting these stem cells into patients who either have cerebral palsies, or like a lot of them have done it on patients of autism. Now, in autism, we know that it does not work, these stem cells, and they have been injecting the mesenchymal stem cells into these autistics. There have been centers in Mumbai also which have been doing it, and one of them is under the flak, because the thing is that they have been extracting a lot of money from people on the behest that these stem cells will provide a reprieve to the sort of a kind of a neurodevelopmentally affected child, where nothing has worked, and they have gone on paying for nearly 2, 3, 4, 5 sessions, and nothing else transpires. So I think the thing is that, see, this legality is something which we have to be very careful of, and only centers which are geared in the proper research format to be able to do things properly should take up this, and it should not be taken up by individuals who are not actually very much into it.
Thank you. Dr. Abdul Waris, sir, I'd like to hear your thoughts on.
I would like to highlight, just summarize the things, what I know about it. Obviously, we don't know much about it. First, I think the stem cell therapies have been started years and decades ago, especially for retinitis pigmentosa. It didn't see any success. Lot of ethical issue. There was a problem in LVPI about 20 years back, and it was all banned and all. Future is genetic therapy. I myself am working on gene therapy, the polymorphism of a raised gene in diabetic retinopathy. And I think future technologies will be genetic therapy related, CRISPR technology related, what I think. Second point I want to highlight is the stem cell therapy works very good for ocular surface diseases. Recently, I was going through a very interesting case in pediatric cataract, where they removed the lens and they inserted the stem cells in the back, and they are thinking that normal crystalline lens will develop. They are working on it. Something very interesting. But for retinal problems, I don't think it has seen much success. As our panelists told, there is a risk of tumorosity. It doesn't take so long term. Results are not very good. I think gene therapy will be the future. And as far as I know, that for stem cells, only Holoclar and there's regenerative patch technology have been approved in the US. And ethical issue is a very big barrier. And I think we have to follow the rules and all. I don't think much future for stem cells in retinal pathologies. I'm more inclined towards genetic therapies.
Thank you, sir, for your input. Dr. Veer, what do you think? Where does stem cell therapy stand today, and how promising is it in for retinal degenerative disorders and inherited retinal dystrophies in the near future? What are your thoughts?
So, like Kairobi ma'am said, that stem cell therapies are in a very early stage, and these are happening at certain centers across the country. So it should be done in a proper facility where the doctors are have researched into this, they are trained into this, and it's not for the regular individual like a regular practicing practitioner. On the coming to the second part, the legality, I feel there are many issues here. The legality, there's a availability, the accessibility, and the application. All of these things, the cost, they are big factors. So back in the day when my wife was pregnant, we came across some of these companies like StemSite. So these companies do have these stem cell banks, and they tell you a lot of things. And in fact, I was curious and I looked up what all retinal and the eye ocular diseases and everything were there, which they claim to be treating. And there was retinoblastoma in it, there was a bunch of other things. And Apollo Chennai was one of the centers where it was being done. So now, even the cost of kind of storing your own bone marrow stem cells was quite high. And in future, what the application is. So personally, I didn't go for it. So I think it's a very initial stage. Maybe yes, 10 years down the line, when they have better banking facilities and better centers around, they are still having very stringent storage, core storage. All the claims are very high, but I think the practical applicability is not so much right now. So that's my take on that.
Thank you so much. Dr. Girish Rao, sir, would you like to comment on the relevance or the importance and probably the future of stem cell therapy in retinal diseases, sir?
I think, yeah. So stem cell therapy as a therapy does have a role in acquired retinal conditions, post-trauma or age-related conditions. Whereas for the inherited retinal dystrophies, probably gene therapy is the way to go about. But right now, I think we are many years away from tangible, easily reproducible, and easily deliverable protocol or procedure. Because in addition to all the challenges, I think, unlike the cornea, the access to the retina is still a challenge. The surgical complexity in accessing the subretinal space and being in the exact location so as to deliver the RP photoreceptor complex with its correct orientation and ensuring that it stays in its place at the point where probably in a geographic atrophy or a traumatic scar where you want it to be there, it's a huge challenge. I mean, in addition to all the other challenges which the other panelists have said. So I think anything which makes the delivery much easier, maybe just as an intravitreal injection or even a needle which goes into the subretinal space without the need for a complex surgery or the need to induce a detachment of the retina, probably yes, those could be the future technologies but there definitely is a need for continuing the research in this, and some of the centers in India are looking at it, hopefully with all the ethics in place. Thank you.
Sir. So there is still a long way to go, and a lot of clarity is required in terms of stem cell therapy for retinal disorders. Anybody else with any other comment?
One thing which you mentioned about the longevity, Aditi, is something which is a very controversial topic because really if it works, you really do not know for how long this is going to sort of last. So that is another one of the issues which is a kind of a gray zone area in terms of stem cells, because something which looks good now may not look good a few years down the line. So that is also something which needs looking into.
Yeah, also clearly highlighted by Dr. Jatinder Singh, sir. Clearly a lot of animal model studies, and then of course different trials are required to understand this, and of course a larger data set or a larger cohort with a much longer follow-up to actually understand how long it works, how it works, and how long it works, and what probably are the short and long-term adverse effects of it. There is still probably a long way to go, so only time will probably tell. So done with all the talks for the day. It's great to have such great teachers and such esteemed panelists for the Retina episode 15 of the GuruSangam. Thank you for all the valuable inputs and the great talks by the speakers, and hope you have a good day. Thank you again. And I would like to thank the program directors, Dr. Santosh Honawar, sir, and Dr. Manoj Mathur, sir, for bringing together people from all different states and different places to share their knowledge and experience today. Thank you.
Aditi,
Thank
you did a great compare.
you.
Bye, everybody.
Bye.
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 Have a good Sunday.
Yeah.
Thank you so much, Aditi. Thank you to Manoj and Dr. Santosh.
Thank you.